High-degree atrioventricular blocks is a very difficult topic to discuss because there is no organised way of looking at these arrhythmias, and in particular, physicians do not understand the differences between those that are malignant and those that are more benign and do not require any intervention. I'd like to commence by paying homage to Wilhelm Einthoven, 1860 to 1927, who was the man who built the first ECG machine in 1901. A few years later, he presented the first organised presentation of normal and abnormal ECGs, and for this he received the Nobel Prize in Physiology and Medicine in 1924. From that time onwards, cardiologists and physicians used the electrocardiograph, the chest X-ray or radiograph, and the stethoscope. And this remained the same when I was a young cardiologist in 1970, but changes soon after that with MRIs, echocardiographs, CT scanning and angiography meant that we had new tools and that the chest radiograph and the stethoscope disappeared. ECGs, however, have been in clinical use for 120 years. They are still the first test requested and performed by a cardiologist and physician, and indeed today are coupled to ambulatory monitoring with expanded indications. So it remains a very important test, and yet very little is taught on electrocardiography, with emphasis though given to the training of the newer investigations. Today's topic are atrioventricular blocks. As physicians, physiologists, we understand that there are three levels of blocks: first degree AV block, second degree AV block, and third degree AV block. What is poorly understood, however, is what lies between second and third degree AV block. Let us first look at third degree or complete heart block, first described by Sir Thomas Lewis. He graduated in medicine as a young man in 1905 from University College in London, and at that time was already communicating with Einthoven, who had presented the ECG machine. By 1 year later, Sir Thomas Lewis had an ECG machine, which you can see is very different to Einthoven's, suggesting that this was made specifically for him. In 1908, just 2 years later, he described the electrocardiograph of what he called complete heart block, and today we prefer to use the term AV block. Complete AV block is not well understood and is confused with many of the other arrhythmias which have got bradycardia. Here we have an electrocardiograph showing complete AV block. We can see the P waves in the stippled red arrows. And what is important is that there is complete AV dissociation. There is no connection between the P waves and the QRS complexes, which occurs in the normal electrocardiograph. We can see a stable, slow ventricular escape rhythm, which is what is usually seen with complete AV block. And the QRS may be narrow or broad. What about second degree AV block? The man who first described this was Karl Friedrich Wenckebach. Before the days of electrocardiography in 1898, He had a patient in her early 40s with an irregular pulse, and what he did using a tuning fork and a pulse was able to determine that from each beat there was a shortening, what we now know as shortening of the RR interval, and there was then a pause. He worked out this relationship later on between atrial and ventricular contractions using the smoke drum, and he called it, we now know, is type 1 second degree AV block or Wenckebach AV block. In 1906, 8 years later, Hay in the UK described type 2 second degree AV block, and it wasn't until 1924 that Mobitz, using the electrocardiograph, differentiated between the two types of second degree AV block and also was able to work out the clinical significance of these. So let's have a look at second degree AV block. Wenckebach, or Mobitz type 1, is a progressive lengthening of a PR interval with a drop beat. It is predominantly in the AV node and therefore has a narrow QRS. However, Wenckebach can also occur in the more distal conducting system. Mobitz type 2 is the PR interval remains constant with a drop beat, and this is in the distal conducting system. The electrocardiograph of Wenckebach sequence is as follows. There is progressive prolongation of a PR interval, which I call AV node fatigue. So we can see the first PR interval is 210, the second is 380, and the third one is 540. Then there is a non-conducted P wave, and the sequence starts again with a short PR interval. We don't always see this classical appearance, particularly on Holter monitoring, and therefore I have in my teaching established what I call the absolute defining footprints. That is, the last PR interval before the drop beat is the longest. We then have the drop beat, and then the one that starts the new sequence is now the shortest. If we understand this, we then can see Wenckebach much easier on electrocardiographs. Mobitz type 2 AV block, however, shows that there is no change in the PR intervals. It is always due to distal disease and never in the AV node. And the definition includes more than one sequential non-conducted P wave if it appears on the ECG. There's a lot of confusion with Mobitz type 2 AV block, particularly with 2-to-1 AV block, which we cannot determine whether it be a Wenckebach or a type 2. So for the definition of type 2 AV block, we have to add one more feature, which is generally not taught nor in the textbooks, and that is you require at least 2 consecutive conducted beats with fixed PR intervals, as shown with the yellow highlight. Also, Mobitz type 2 AV block generally also occurs with bundle branch blocks, and in this situation, a bifascicular block, which aids in the diagnosis, although Mobitz type 1 Wenckebach block can also occur in this situation. So now let us go back to our diagram and look at that question mark that lies between what we now understand as second degree AV block and third degree or complete AV block. And there are 2 major groups of ECG abnormalities. The first are the broad QRS, no drop beats, which we know as the bundle branch blocks. There's a whole lot of these. There's an incomplete, fascicular, bifascicular, intravascicular, and so forth. To the right now, we have a group of ECG that really are not categorized, and for this lecture I've called high-degree AV blocks. There is, however, a high-degree AV block, which is an atypical Wenckebach type block with two or more non-conducted sequential P waves, as shown here. 260 milliseconds and then down to 220. So this is a Wenckebach block, and we got 2 drop beats. We call this high-degree atrioventricular block because Wenckebach, in his description, only described 1 drop beat. I prefer to call this also Wenckebach, but rather an atypical Wenckebach. Now let us return to high-degree AV blocks. They lie between, as we can see, second degree and complete AV block. They border complete heart block where AV conduction, although fragile, remains at least partially intact. Most of these are serious conduction system blocks with broad QRS complexes and non-conducted P waves. But what is going to be important in this lecture is that not all of these are serious conduction system blocks. The list, as we showed you earlier, has the high-degree AV block, which we've now discussed. I'm not going to discuss the second last one, pan-conduction defect, because it is simply one of the above ones together with known sinus node disease as well. So excluding those, we're left with 5 types of ECG abnormalities. Let us have a look at the first one, advanced AV blocks. Here there is severe degeneration of a conducting system with 3 or more consecutive blocked P waves. AV nodal disease can occur, or it's associated with a bundle branch block and it's infranodal with multiple other conduction blocks involved. So here we have an ECG of a significant bradycardia. We can see that there is a 3-to-1 block, and as well as that, there is a left bundle branch block. What about the next one, a trifascicular or bilateral bundle branch block? I'll give you a number of examples of these. Firstly, the level is always beyond a bifascicular block, and we can see here an electrocardiograph where there is a left anterior fascicular block, and the bottom tracing of the same patient shows a left posterior fascicular block. As well as that, there are a right bundle branch block as well. So here we have a patient showing disease in all the bundle branches, the 2 fascicular branches of the left and the right bundle branch block. Another one is a bifascicular block with 2-to-1 AV block. So here we have a left posterior fascicular block, a right bundle branch block, as well as that, a 2-to-1 AV block. So both of those ones I've just shown you are serious, severe, and require cardiac pacing. A third group is where we have right and complete left bundle branch block. Here we have a situation where we have a left anterior fascicular block, a right bundle branch block, and shortly after this dramatic electrocardiograph where there is now a left bundle branch block as well as a 2-to-1 AV block. This obviously is very serious conduction tissue disease and requires pacing. The third group were the alternating bundle branch blocks. Here we have an electrocardiograph with a left bundle branch block and a right bundle branch block. This is not an alternating, but rather we can see that this is truly a left bundle branch block with sinus rhythm, and we also have a right bundle branch block with sinus rhythm and the same PR interval in the same patient, and this also suggests very severe conduction system disease. And then there is the confusing multi-level blocks. I will show a number of these so that you can understand how complicated it may become. The first one is alternating Wenckebach AV block. Here is an ECG, and to the eye it looks like complete heart block, and nearly always it's called complete AV block. It's sinus rhythm, and there are irregular QRS complexes. In my definition of complete AV block, I said that we have a slow ventricular rate, which is usually very regular. This one is somewhat irregular. Is there a pattern there? So let's go back to the ECG, and we can see now that we've got this sinus rhythm, and we have 3 of the beats, and if you follow it, you can see that this is a classical Wenckebach increase in the PR interval, a drop beat, and then the sequence starts again. So it's classical Wenckebach, no argument there at all. But what is going on is that between these beats, there is another P wave. And this P wave shows complete AV block. So now there are 2 blocks in this heart, one probably proximal, and the other one may well be more distal. 2 blocks at different levels. This situation is not always pathological. I'd like to show that what happens here is that there are 2 drop beats in sequence. And you can see that rather than a blue stippled arrow following it with a third, the normal conduction takes over. It appears to be a protective mechanism to prevent marked bradyarrhythmias. Now let's have a look at this patient with atrial flutter. We're all used to seeing atrial flutter rates of 200 to 300 beats per minute in the atrium, and we can either have a regular or, in this case, an irregular ventricular response. What is this response? Well, let's look at it by looking at the P waves, and we can see that there are 3 to begin with, conducted P waves, and then a drop beat. Here is that sequence, and there are the increasing PR interval, and then there's a drop beat. And then the sequence starts again. As well as that, we have alternating P waves with complete AV block. And you can now see that there are 3 non-conducted P waves, this occurring without a significant ventricular pause, and it appears to be that this is physiologic and protective. So not only are these multi-level AV blocks pathological, but they could also be physiologic and protective. Here is another example of a multi-level AV block. This is a Wenckebach AV nodal block as well as one in the fascicle. So let us examine the electrocardiograph. Sinus rhythm, and one can see a sequence with increasing PR interval, a drop beat, and then the sequence starts again. As well as this, we actually have changes in the QRS width. The first complex has a normal QRS, and the second one clearly abnormal with a left bundle branch block configuration. So let's now add this to the sequence. The first QRS is 110 milliseconds, the second 150 milliseconds, and the third one 170 milliseconds, showing an increasing block in the left bundle branch, one of the fascicles, and as a result of this, this is also a Wenckebach type block, but distal to the AV node. Once again, the QRS complex is normal. I'd like to now discuss the last block on that list, which is paroxysmal AV block, which is very poorly understood. By definition, on the electrocardiograph, there is a run of drop beats or ventricular standstill or asystole, often resulting in syncope. The term paroxysmal is given to this, and people cannot understand why, but it is logical in that these are paroxysms that come suddenly and maybe one or more, and therefore, by definition, they are unexpected clusters of ventricular standstill. Let me show you an electrocardiograph. Here we can see clearly the ventricular standstill, and in yellow, and now we have some escape rhythm, which is either a junctional rhythm or maybe a fascicular rhythm, and then it goes back to a completely normal ECG. That is what happens with paroxysmal AV block. It's usually called complete AV block, but this is not so. If you remember from the definition I gave earlier on, there is an irregular escape rhythm and it's stable. This is not a stable rhythm. So there's confusion, there's a plethora of names, each unique to the author, there's a poor understanding of the etiological mechanisms, there's a very poor understanding of electrocardiograph, and as a result of this, treatment may be very inappropriate. There are 3 known subgroups. I've added another one to this list, and as you can see here, the first 2 are the important ones. The term extrinsic and intrinsic is in regard to the conduction tissue disease. So intrinsic suggests advanced conduction tissue disease. Extrinsic means that there is normal conduction system, and that external, extrinsic factors such as the autonomic nervous system and heightened vagal tone play a big role. We can separate them by age, syncopal triggers, prodroma, length of history, associated heart disease, response to treatment, and in particular, the ECG findings, which we will define in this lecture. So let's look at the extrinsic paroxysmal AV block. Extrinsic meaning outside the conducting system, and the conducting system is usually normal. It is vagal mediated. The patients are often young, well, and fit. There are parasympathetic provoking triggers. These include stress, dehydration, standing, going to the dentist. And the patient can recognize what's going to happen by prodroma, including an intense abdominal sinking feeling, nausea, sweating, even vomiting. And there is a slow sinus rhythm. And once the heightened vagal tone dissipates, there is a rate acceleration of the sinus node. What I'd like to describe it as is think Wenckebach with high degree AV block. And there is generally a narrow QRS. Let us have a look at an example. Here is a patient which we can see on the top tracing. There is a classical Wenckebach AV block, a longest PR interval before the drop beat and the shortest after it. And then it goes on to a ventricular standstill without any escape rhythm whatsoever. And you will note that the sinus rate is stable or slow during this. It doesn't increase. And only when it terminates does the sinus rate increase. So let us have a look at a progression. Firstly, there is a Wenckebach AV block on the left going on to 2-to-1 AV block, which is clearly due to a Wenckebach. And then it goes on to a ventricular standstill, and you can see there is no escape rhythm and the patient has a syncopal attack. Although this looks very serious, it's in a young patient who's been having it for many, many years, and the treatment is not to rush in and implant a pacemaker. There is a lot of confusion, and it tends to blend with neurocardiogenic syncope. Whereas neurocardiogenic syncope is traditionally involving the sinus node and peripheral vasodilatation, neurocardiogenic syncope can also have, as you can see here, a Wenckebach response, but no drop beat because there is asystole. Now let us look at intrinsic paroxysmal AV block. The term intrinsic means that there is disease in the conducting system. Some authors only recognise this type of paroxysmal AV block. There is advanced conduction tissue disease. The block is usually infranodal, of course. Unlike the extrinsic, the patients are elderly and have concomitant heart disease. There are no consistent clinical triggers. It just occurs abruptly with few or no prodroma. And think type 2 AV block with high degree AV block. And the sinus rate may actually increase now during ventricular standstill because there's no heightened vagal tone. Bundle branch blocks are common. And what is particularly important with the electrocardiographs of this group is that there is a role for ectopy. Ectopy may initiate or terminate a ventricular standstill sequence. Let us have a look at some examples. Here we have a non-conducted atrial ectopic beat. You can see there, yellow highlight, and that commences the period of ventricular standstill. There is severe disease and conduction, although it appears on the surface ECG to be normal, we need just a stimulus from an early premature beat to prevent conduction through this disease heart because of phase 4 remains flat. And this is what happens. An atrial ectopic, as you can see here, again, narrow QRSs, although often we can see a wide QRS. Here is the atrial ectopic beat commencing, whereas there is an atrial couplet here, and it too commences a period of ventricular standstill. Ventricular ectopic beats can also stimulate a ventricular standstill sequence. What about terminating? Well, once a standstill sequence starts, it's very difficult because of a disease in the conducting system to get the thing to start conducting again. We often need a stimulus from a junctional or atrial ectopic beat to come through and reset the action potential so that now, as you can see, it conducts normally, and you can see with a very fast heart rate. A junctional escape beat doing it, whereas a ventricular ectopic, particularly with a bundle branch block, may also reset the asystolic pause, and it starts conducting again, and notice it conducts normally with a normal a normal P2P interval. A hybrid paroxysmal AV block is a term that I should give to those ECGs where there is confusion as to which group it really is. In this case, the person was young, had a very marked first-degree AV block, and there were no triggers or nothing to terminate, and therefore there is no way in which we can call this external, extrinsic or intrinsic, but rather we just give it a name, a hybrid, and although it behaves like extrinsic, there's a marked first-degree AV block suggests that there is some conduction tissue disease, and of course treatment depends on symptoms. The fourth group is well known but very rare. It's called an idiopathic paroxysmal AV block. It's a generic ECG, features without any sinus rate changes, there's no broad QRS, there's no triggers. There's no structural heart disease. Again, it has an abrupt onset, but this type of tracing, we look for low levels of endogenous adenosine because there can be a reasonable or therapeutic response to theophylline, although dual chamber pacing also may be necessary. So let's have a look at an ECG that fits this criteria. As you can see, it is a beautiful example of a paroxysmal AV block. The P2P intervals don't seem to change much, and there are no escape beats present. There we would look for other reasons, and that's why we call it idiopathic. Finally, I'd like to show a rhythm that's not sinus. This is atrial fibrillation with very long pauses. And again, this occurred in an otherwise reasonable halter without many significant pauses. These just occurred in paroxysms. And I wonder that is this paroxysmal AV block? Because remember, we don't require the sinus node in paroxysmal AV block. We just require P waves to make our diagnosis. But in theory, it may also occur with atrial fibrillation. So what have we learnt? High-degree AV blocks are an obscure group of bradyarrhythmias that lie between second-degree and complete AV block. They border complete AV block, where AV conduction, although fragile, remains at least partially intact. Most, but not all, are serious conduction system blocks with broad QRS complexes and non-conducted P waves. It is important, though, to recognise heightened vagal tone to prevent inappropriate therapies such as pacemaker implantation. Thank you very much, and we can now have time for question and answers.